All right, everyone. Thanks for joining us for our next CEDSS seminar. Um, so, and the next one will be on October 15th from Paul Bartis. And just keep that on your calendars. So we'll be looking forward to hearing from him and his Cancer Informatics and Precision Health Institute. But today we're really excited to have Eric Fung, who's a senior medical director of GRAIL. Dr. Eric Fung is a vice president in clinical development at GRAIL, where he leads several clinical development programs in support of development of a blood-based multi-cancer detection test. Dr. Fung has previously held clinical development R&D leadership roles at Affymetrix, Vermilion, Cephagen, and Roche Molecular Diagnostics. Dr. Fung has led clinical trials leading to FDA clearance of multiple IVD products. Dr. Fung received his MD, Ph.D. from the Johns Hopkins University of Medicine. And so we're really excited to hear about his talk on multi-cancer detection of early stage cancers with simultaneous tissue localization using plasma cell-free DNA-based targeting methylation assay. So really a pleasure to have you here today and let you take it away. So thanks so much.
Thank you, Ryan. Well, thank you very much for the opportunity to present today. I'm really excited to be able to present our work on our cell-free nucleic acid technology to be utilized for multi-cancer detection. So this is my disclosure, and obviously I'm an employee and shareholder of GRAIL. So what I'd like to do is start with discussing the current state of cancer detection as we see it today. And I think everybody on this call is aware that today many cancers are detected too late, that in fact the majority of cancers present with regional or distant metastases. And so if we look at three of the most common cancer types, breast, colorectal, and lung, and bronchus, you can see the range at which we have non-localized disease at the time of diagnosis. And one thing to note, of course, is that all three of these cancer types do have screening paradigms. We obviously have mammography for breast cancer, a variety of screening approaches for colorectal cancer, usually culminating in colonoscopy, and then low-dose CT for a very specific subpopulation of high-risk individuals for lung cancer. And so the impact, of course, on this later diagnosis is, of course, that it's costly to treat, but just as importantly, or more importantly, it has a high rate of cancer deaths. And so if we look at the disparity between survival of cancers that are detected early versus those that are detected late, you can see the substantial difference. And so if we look at, for example, all cancers, there's close to 90% survival when cancer is diagnosed early, and only a 21% survival when it's diagnosed with metastatic disease. And if we look at lung cancer, which is one of the most common cancers, you can see that even with early cancer diagnosis, the survival rate is 56%, but with distant metastasis, it's as low as 5%. So how can we improve our survival? And we really think about it in the context of early detection at GRAIL. Now, the paradigm of early detection is really reliant today on cancer screening. And so we have guideline recommended screening paradigms for several cancers. And so you can see breast, cervical cancer, colorectal, and lung all have United States Preventive Services Task Force recommendations of A or B. Prostate historically has had early on had a guideline recommended screening, but that has of course been curtailed due to overdiagnosis. And we'll talk about the issue of overdiagnosis later in this presentation. One of the things I'd like to point out is the importance of positive predictive value in cancer screening. The reason positive predictive value is probably the most important metric of how a cancer screening test performs is that it tells us how often a positive result on that cancer screen is likely to actually be cancer. And so while we think about most diagnostic tests in the context of sensitivity and specificity, It's really the positive predictive value, or PPV, that drives the ability of physicians and patients to have certainty in the result of that screening test. And this is highly dependent, particularly in cancer screening, because of the relatively low prevalence of cancer in the population. And positive predictive value is driven very much by the prevalence of a disease, especially when that prevalence is low. So if we look at the current screening paradigms and the positive predictive value of these screening paradigms, you can see the value of the positive predictive value currently for those cancer types. And you can see that they range from very low single digit to about some 19% for cervical cancer screening. So while you can see for sensitivity and specificity, those numbers are all very close to 90%, which is what you typically expect for a diagnostic test. Because of the low positive predictive value, even with high sensitivity and specificity, we have relatively low positive predictive value in the single digits. And we'll return to this as an important concept for how we can change the field for cancer screening. So of course, individuals are at risk for more than one type of cancer. And so what you saw on the previous slide were 4 screening paradigms. So if we think about a woman who is at risk for breast and cervical cancer, potentially also for lung cancer and colorectal cancer, and if she were to undergo all of the screening types you saw on the previous slide, because there's a cumulative false positive rate across these cancer screens, this woman undergoing all of those screening types would actually have a 37% cumulative false positive rate. And you can see the underlying false positive rate for each of those individual cancers. And you can imagine then that a woman who has one of these false positives would undergo follow-up tests or certain types of interventions. And so when we think about the current state of screening individuals for individual cancers, as opposed to screening individuals for a multitude of cancers, you can see where we might introduce these false positives. And that's why we believe that there's value to a multi-cancer approach for cancer detection. As we transition then from conceptually screening for one cancer at a time to screening for multiple cancers at one time, we have to think about the benefit and risk ratio. That is to say that while we think about cancer detection as a quote unquote good thing, there are risks associated with cancer detection paradigms because no test is perfect. And so we need to understand what are the criteria for evaluating a multi-cancer early detection test. And we'll return to many of these things later, so I'll spend a little bit greater time talking about each of these individual points. So of course, a multi-cancer early detection test should be able to detect a diverse set of cancers. And of course, we hope that it will detect the deadly types of cancers. We talked a little bit earlier about prostate cancer and the concept of overdiagnosis. That is to say, diagnosis of cancers that would not otherwise hurt or kill an individual. So on the flip side, of course, we can think of many cancers that we are quite aware of as being deadly, such as ovarian, liver, lung, pancreatic, and so forth. We also want to think about how we can take a blood test, which is interrogating cell-free nucleic acids that are circulating, and how we can translate that into a tissue of origin. That is to say that we need to provide physicians an idea of where the cancer might be arising from so that they can efficiently work up the patient. One of the most important elements you'll see at the bottom left is a very low false positive rate. And as we talked a little bit earlier about the positive predictive value, that is to say the percent of positive results that actually indicate cancer, given the relatively low prevalence of cancer, we need to have a high specificity, which is conversely a low false positive rate, to try to improve on that positive predictive value. And so you'll see later on in this presentation how we have set a very low false positive rate in order to help maximize the positive predictive value. Related to this concept of prevalence, that a multi-cancer early detection test needs to be applied to appropriate populations. And so if you look at the USPSTF guidelines for cancer screening, they really look at the prevalence of cancer to try to get an assessment of the benefit-harm ratio. And so as an example, low-dose CT is utilized in a very high-risk smoking population because there's a higher prevalence in that population. So as we think about multi-cancer early detection, we have to think about a population to which we can apply this test that would benefit. And so as an example, we can look at individuals who are greater than 50 years old, who have a higher prevalence of cancer than those who are less than 50 years old. I also wanted to talk about the balancing of sensitivity and specificity to optimize overall cancer detection that's related to this false positive rate. But as everybody knows, sensitivity and specificity are inversely correlated. And so as we think about what cutoff to apply as we develop this test, while we do want to achieve very high specificity and a low false positive rate, we need to ensure that we can identify an adequate number of cancers such that the benefits outweigh the potential harms. We talked a little bit about overdiagnosis earlier in the setting of prostate cancer, and we'll talk a little bit later in this presentation about how the molecular biology of cell-free nucleic acids for cancer detection really support the concept that this approach will reduce or minimize overdiagnosis. And then lastly, the development of any novel test that might be applied at a population level needs to be supported by population scale clinical studies during the development and validation of that test. And we'll talk during this presentation about the clinical evidence supporting a potential novel multi-cancer early detection test. So as I indicated, our approach is to look at plasma cell-free nucleic acid. And so cancer-derived cell-free nucleic acid typically arises due to apoptosis of cancer cells and release of that cell-free nucleic acid into the circulation. We'll talk a little bit later about how this biology translates into certain characteristics that we can identify at a clinical level. Of course, the genome of a cancer cell is quite complex, and there are various kinds of aberrations that one can measure. And if you look in the box on the right, we can actually interrogate a number of these different kinds of aberrations. These include single nucleotide variants, SNVs, as well as indels. They can also include copy number aberrations, and then DNA methylation patterns, or epigenomics. And so early on in our assessment of cell-free nucleic acid for cancer, we actually interrogated all three of these. And so we ran a number of samples, cases and controls, and ran all three assays on each of these samples and asked ourselves, was there improved classification of cancer and non-cancer, as well as improved localization of cancer? That is to say, being able to identify a cancer as coming from a specific organ using one or more of these technologies. And at that time, we didn't know whether a single one of these approaches would work, or whether we might need to measure two or all of these types of aberrations. So on the basis of our early results from this study, we actually localized that DNA methylation patterns would actually provide us adequate information to ask the two questions. That is to say, is there cancer? And if so, where does that cancer come from? And so we have since then focused entirely on DNA methylation in the development of the data that you will see in the rest of this presentation. So just to give you a sense of what this looks like, here is a zoom in on the methylation pattern for a gene surfactant B, which I think many of you will realize is a gene that's expressed in lung. And so you can see if we look at alveolar epithelium, we can get a very different methylation pattern than if we look at epithelium that comes from the colon or comes from the breast. And so looking at methylation actually makes a lot of sense, because methylation is one of the key drivers in cellular differentiation. And so again, if we think about those questions we need to answer about the presence of cancer as well as the localization of the cancer, it is uniquely suited to answer both of those questions, in contrast to, for example, copy number aberrations or SNVs. And so if we look at that question of differentiating cancer from non-cancer, if we look at a non-cancer participant versus a lung cancer participant, we can actually, in the same region of chromosome 10, see a dramatic difference in methylation patterns in the individual with cancer versus the plasma. And if we sequence the tissue sample from the same individual with cancer, we get a similar, but not always identical representation of that methylation signal. A lot of this has to do with the heterogeneity of cancer cells within a sample, as well as the amount of shedding and kind of shedding that we see in the circulation. But suffice it to say that there's adequate data and information in the plasma sample to both distinguish cancer from non-cancer, as well as distinguish lung cancer from other types of cancer. So CCGA-1 was the initial sub-study where we ran all three types of assays, the SNV, the copy number, and the methylation analysis. And from there, we decided to focus on methylation. And our initial work was done on whole genome bisulfite sequencing. But we asked ourselves whether we could actually do targeted methylation as opposed to whole genome bisulfite sequencing. The advantage of moving to a targeted approach would be that we could sequence more deeply, and sequencing more deeply might help us with limited detection, which might therefore help us with clinical sensitivity. In order to make this transition from whole genome bisulfite sequencing to a targeted panel, we needed to create a panel. And in order to create that panel, we needed to identify the appropriate targets for inclusion in that panel. In order to do this, we took a large number of cancer samples from our CCGA, or Circulating Cell-Free Genome Atlas study, and we'll talk in greater detail about the CCGA study. And so we took this data. We also needed non-cancer samples as controls, as well as public sequencing data from, for example, TCGA. And so by applying cancer samples, non-cancer samples, both from blood and from tissue, we could apply machine learning to identify the regions that could answer those two questions: cancer from non-cancer and cancer versus other cancers. And so we believe that this methylation database is probably one of the largest that exists in terms of being able to have the number of samples of both cancer and non-cancer samples. We decided to design two kinds of probes for inclusion in the panel, both hypermethylated probes, that's to say selection of methylated fragments, as well as hypomethylated fragments to select for unmethylated fragments. The conclusion of both kinds of probes actually provides us a more complete picture of the biology that we are interrogating in the blood. That is to say that it allows us and supports the thesis that we can look at both hypermethylated and hypomethylated regions to help answer both questions of cancer presence as well as cancer types from each other. This is a summary of what that targeted methylation panel looks like. And so you can see that it has a targeted region of 17 megabases and covers about, the probe regions cover about 31 megabases. And it comprises about a million probes. And so as I indicated, we have a mix of hypo and hyper methylated probes. And the last thing I wanted to mention is that they largely interrogate, as you can see, promoter, intron, and exon regions. And so it really is a good representation of the whole genome, but is focused on regions that have been identified in the studies that you saw in previous slide for informative regions, and therefore is much more efficient than whole genome bisulfite sequencing. So with that as a backdrop, we've discussed the biology and the development of the targeted methylation pattern. We need to make sure that we have the right clinical samples on which to train and validate our multi-cancer test. So what we see here are 4 of the major clinical programs that GRAIL has undertaken. And I'll talk about these in very brief detail, but we'll focus largely on CCGA. CCGA is a Circulating Cell-Free Genome Atlas study. It enrolled about 15,000 individuals, both cancer and non-cancer, and it's a case control study. And it's really used to develop and validate our new novel test. STRIVE and SUMMIT are both cohort studies. And you can see STRIVE is about 100,000. It was a study undertaken in women who are undergoing mammography screening. And SUMMIT is about 25,000 individuals, and it is specifically focused on individuals who are at risk for lung cancer. So it's a high-risk smoking population. And then PATHFINDER is a study that we just initiated earlier this year, and it is an actual implementation study. That is to say, how is the test utilized in a real clinical setting? in aggregate, you can see that these studies encompass over the 140,000 participants. So I said that we would talk about the circulating cell genome atlas study in great detail, and that's because it really is a foundational study on which we have been developing this test. So as I indicated earlier, our very early studies were looking at SNVs, copy number changes, and methylation patterns. We focus on methylation patterns, and we've utilized much of CCGA for training and validation of this targeted methylation panel. In terms of the study design, these are 15,000 participants. On the cancer arm, these are newly diagnosed cancer individuals, and the non-cancer arm are individuals who at baseline are thought not to have cancer. One of the most important elements of this study is the follow-up, because follow-up allows us to answer two questions. In the cancer arm, it allows us to look at survival, and that survival question can help us address overdiagnosis. And in the non-cancer arm, individuals who were non-cancer at enrollment develop cancer at a certain frequency over time. And we can look at whether that baseline signal that we saw is indicative of a future cancer. So for all 15,000 participants, we collected blood, and for the individual with cancer, we attempted to collect tissue as well. That tissue sample is very helpful in comparing the blood signal from the tissue sample and tells us a lot about the underlying biology. So this is a busy slide, and I will not go into it in great detail, other than to say that in CCGA substudy 2, we have, as I indicated earlier, a large group of cancer participants and a large group of non-cancer participants. We supplemented this study with a group of non-cancer participants from STRIVE, our women mammography cohort. And the reason that we supplemented CCGA with a large number of non-cancer participants was that we wanted to ensure that setting a very high specificity threshold, we had an adequate number of non-cancer participants on which to train, as well as validate that cutoff. And so by taking these non-cancer participants from STRIVE, we can increase the number and reduce our width of the confidence interval around that very high cutoff. So I won't go through the entire concept diagram and just turn your attention to what we finally used in the analysis population, which was in training 3,000 participants and in validation 1,200 participants. We'll talk a little bit in greater detail about these participants. So you can see training and validation, each had cancer and non-cancer participants, and we can talk a little bit about the distribution of various characteristics, slightly skewed toward females, particularly in the non-cancer arm because of that inclusion of the STRIVE cohort. You can see that it's a little bit higher white population, and I think that reflects a lot of clinical studies in the United States. If we look at the BMI, this is pretty similar to what we might see in the United States. And then the smoking, because smoking obviously has a relationship with cancer, you can see the smoking status of the individuals with obviously in the non-cancer arm, a bit higher percentage of people who have not smoked. If we focus on the cancer group, you can see the stage distribution. And this is actually one of the benefits of a case control study. As you might suspect, in a cohort, and there are subtleties in a cohort study about a prevalence screen and incidence screen, but suffice it to say that in a cohort study, it's very hard to get representation of early stage cancer as well as very specific types of cancers. But in a case control study, we could actively enroll some of the more rare cancers, such as ovarian, pancreatic, esophageal, and so forth, as well as ask our clinical sites to focus on providing earlier stage cancers. And so you can see that we have a roughly even distribution of cancer stages. So in terms of the results, what we'll show here is the test set. So as we indicated earlier, there's a training set and a test set or validation set. We're going to focus on the results of the validation set because that's, of course, the important data to present. We actually had a pre-specified set of cancers prior to going into the analysis. And this pre-specified cancer set was based on a combination of their performance in the first substudy of CCGA, as well as how lethal they are. So you can see that many of these are ones that we are very familiar with as being high mortality cancers, so colorectal, esophageal, head and neck, liver, lung, ovary, pancreas, stomach. And what you can see here as we stratify by stage is that, as you might suspect, the sensitivity improves as a function of stage. And so you can see that we have over 90% sensitivity for stage 4, close to 90 for stage 3, and about 75% for stage 2, and about 30% for stage 1. If we look at all the cancers in the CCGA study, you can see the difference. And one of the reasons for this difference is actually the presence of a number of cancers that, that the test does not detect as readily, which includes some forms of breast cancer and prostate cancer. Let's return to this concept in a short bit about the performance in some of these cancers, and in particular prostate cancer, where we've already talked about overdiagnosis. If we go into greater detail here on some of the more common cancer types, we can see this in greater detail. So you can see in breast cancer, we can have close to 100% sensitivity in the late stage, about 50% sensitivity for stage 2. And you can see actually relatively low performance for stage 1. There's actually a differential performance for hormone receptor status. And so we again believe that this relates to some of the molecular biology of cell-free nucleic acid signals, including how the shedding rate of a cancer might reflect its aggressiveness and how that shedding rate translates into sensitivity. And we'll return to that concept in just a short bit. We also talked about prostate as having that lower sensitivity in the early stages, and you can see again there. And we are well educated on the concept of overdiagnosis in prostate cancer. And so this relatively low sensitivity of prostate cancer may again reflect that indolent nature of many of these cancer types. And so the lack of detection of these indolent types of prostate cancers may actually not be a bad thing, because we do want to, at a population scale, reduce overdiagnosis. And so if we look at these other high mortality cancers, such as pancreas, you can see very good sensitivity even as we move down to stage 1. And if you look at lung, very high stage sensitivity for the late stages, lower in stage 1. There's an interesting phenomenon in lung cancer. As I think everybody on this call understands, lung cancer is actually a heterogeneous population of lung cancer subtypes, such as adenocarcinoma, squamous cell carcinoma, and other types of lung cancer. Turns out that we have differential sensitivity for these different types, with adenocarcinoma being a lower sensitivity than squamous cell carcinoma. But conversely, generally speaking, adenocarcinoma has slightly better prognosis than squamous cell carcinoma. So again, there seems to be an association between aggressiveness of disease and the shedding of cell-free nucleic acid, which translates into detection. And again, we'll return to this as we look at some Kaplan-Meier curves. So one of the things that I wanted to mention is that these sensitivity numbers are pinned at very high specificity, 99.3% specificity. And again, there is an inverse relationship between sensitivity and specificity. But as we think about application in a general population, that high specificity is absolutely critical. And so pinning to that high specificity means that we have a 0.7% false positive rate. And so again, we believe that this is what is necessary to achieve good positive predictive value in a clinical setting at the population level. If we look at the sensitivity now for non-distant metastatic disease, so stages 1 through 3 of these cancer types, you can see that the sensitivity tends to be close to 70% or higher, slightly lower for lung. And one of the elements here is spectrum bias. That is to say that there is a certain distribution of cancer stages as well as cancer subtypes that's a reflection of a case control study. So these numbers may not actually be translated specifically into a general population, because a general population will have a different composition of the cancer types. We'll talk a little bit later about the impact of real-world population cancer distribution and some modeling that we've done to translate these numbers into performance that we think might occur in the real world. I wanted to focus a little bit on overdiagnosis and the concept of ensuring that our multi-cancer early detection test does not lead to overdiagnosis, which can lead in of itself, overdiagnosis can lead to unnecessary workup, unnecessary treatment, and other kinds of adverse events. So if we look at Kaplan-Meier curves that describe the survival in our cohort and stratify by stage, we can stratify individuals by whether the multi-cancer early detection test detected or did not detect the cancer. And what you can see on a stage-by-stage basis, that the undetected cancers had better survival than the detected cancers. And so one of the important elements here is that what we're seeing is that the undetected cancers tend to perform better than the detected cancers. And this occurs on a stage-by-stage basis, which means that this phenomenon is independent of stage. And so if we do a multivariate analysis, you can see that, as you might suspect, stage is probably the most important predictor of survival. But when we look at independent factors, you can see that the targeted methylation panel detection is just as much, is also a very good predictor of survival. You can also see that current screening paradigms are actually do an interestingly well job of determining survival. And that's, of course, because of the high quality of early detection of, for example, breast cancer, colorectal cancer, and lung cancer that LDCT mammography and colonoscopy can provide. So I talked to you a little bit about spectrum bias, and what spectrum bias tells us is that there's a certain distribution in our study that might not actually reflect the distribution in the general population. And so we need to translate the performance in this population to what we might see out in the real world. So SEER, which is the Surveillance for Epidemiology and End Result database of cancers that are diagnosed in the United States, can help us adjust the spectrum that we see within our study to what you might see in the general population. So these are somewhat busy slides, but I'll walk you through them. So what we've done is we stratified our signal detection by stage. And what I'll do is I'll focus on stage 4 because that's the most interesting result. So the solid line is the actual survival rate of our population. So you can see this is the non-detected stage 4 participants, and the solid red line is the detected stage 4 participants. But this, of course, reflects the distribution within our population. So if we actually adjusted for the CCG, for SEER population, you can see that the population of the not detected and the detected types of cancers would be very close to each other, meaning that in the real world, there's actually very little prognostic difference between those two populations, as opposed to what we see in this population. And what you can see, second of all, is that the solid blue line is substantially higher than the blue line that you see here, the dashed blue line here. And so what that tells you, this very large difference between the solid blue line and the dashed blue line tells us that there's actually a substantial difference in survival from what you would have expected. And we believe that this reflects some of the molecular biology of cell-free nucleic acid detection, namely that there is a shedding rate that cancers have, and that indolent or the less aggressive cancers shed at a lower rate than the aggressive cancers. And the aggressive cancers, of course, have a higher mortality. You can see that this phenomenon holds true at all stages. So if we go back to stage 3, again, you see the blue line, solid blue line is much higher than the dashed blue line. And again, you see it here in stage 2 and even at stage 1. And in fact, in stage 1, the non-detected cancers have a very good prognosis. So we believe that the technology in of itself of looking at cell-free nucleic acid signals actually has a very good chance of avoiding some of these overdiagnosis issues that have plagued, in particular, cancer screening for prostate cancer, as an example. I mentioned to you earlier that one of the key attributes of a blood test for cancer is that it should be able to provide some level of information to the physician about where that cancer might have arisen from. And so what you see here is a confusion matrix of cancer tissue of origin localization. And so what we have on the x-axis are the actual origin of the cancer, and on the y-axis, what the classifier predicted to be the origin. And so you can, as you might suspect, the diagonal reflects the answers in which the localization was correct. So as an example here in this bottom left corner, you can see the actual tissue of origin was uterus, and what we called as uterus, it was correct 8 times. There was one actual uterine cancer that was mislabeled as a lymphoid neoplasm. And so we can walk across the diagonal and see what that accuracy is. And you can see that, first of all, that we were able to assign a tissue of origin call to 96% of the cancer samples. And of these, 93% of those calls were correct, which tells us that we have highly precise localization to a specific tissue of origin across all of these tissue of origin sites. I won't go into it in great detail, but there's a little bit of crosstalk around some certain etiologies. And so, for example, we might get a little bit of crosstalk between HPV-related cancers. And sometimes when we have similar histologic subtypes, such as squamous cell of the lung and squamous cell of the head and neck, so there may be some crosstalk there. But the underlying epigenetics pattern is often very, as you can see from this data, is often quite conclusive. There are some questions we've been asked whether sites of metastasis can confound the tissue of origin localization. So we might have a cancer that has metastasized to the lung. Does there now a lung signature that overrides the tissue of origin from which that cancer metastasized originally? And the answer is actually generally we can identify the original tissue of origin quite well. So just to summarize, the key performance features of this multi-cancer early detection test is that we can detect a large number of cancer types. Now, I mentioned to you that the spectrum bias means that we have a certain distribution in a case control study that does not represent the distribution out in the real world. And I also mentioned to you earlier that positive predictive value, which is highly a function of the false positive rate as well as the prevalence of cancer, can be not calculated from a case control study, but we can actually model it. And this is actually one of the most important arbiters of the value of a screening test. And you saw on an earlier slide, many of the screening tests that are currently used today have single-digit positive predictive value. So when we apply the sensitivity and the specificity or the false positive rate from our study and apply it to a seer population, and so we can now model a positive predictive value, we can achieve a 42% positive predicted value in this model set, which is substantially higher than currently utilized cancer screening tests. And so this is one of the fundamental reasons we believe that the paradigm of screening for individual cancers will evolve to include multi-cancer early detection in the future. And lastly, I wanted to just reiterate that the ability to identify the localization of the cancer was achieved over 90% of the time in this study. So if we just hypothesize what this might look like in the real world, if we go back to the 4 cancers for which the USPSTF has provided A or B recommendations, that is to say cervical, breast, low-dose CT for a very specific population, and colorectal, based on the positive predictive value and performance characteristics of those tests, that if we apply that to the population today, we can see that we could detect 200,000 cancers at a cost of over 8 million false positives. So the signal to noise ratio is about 1 to 41. If we apply our multi-cancer early detection test, you can see because of the high positive predictive value that we could detect more cancers, because in aggregate, we're looking at a lot of additional types of cancers, as well as the fact that USPSTF only recommends lung cancer for a specific subpopulation. And in fact, more lung cancers occur outside of that population than within that population, that we can actually detect more cancers at a cost of fewer false positives and achieve a much more favorable signal to noise ratio. And so if we look to the future and combine USPSTF guideline recommended screening along with a blood-based multi-cancer early detection test, we would then be able to have an aggregate of 650,000 true positives at a cost of only an incremental small number of false positives. Most of these false positives actually come from the USPSTF screening, and a much more favorable signal to noise ratio. And again, this is modeled on what the SEER population might look like, overlaying current performance characteristics of both standard screening and the multi-cancer early detection test that we've just been talking about. So as we think about the future, we believe that this multi-cancer early detection test can be integrated into existing clinical workflows. Much of our work today has been done in collaboration with many oncologists, but in the future, this type of test will be implemented in the primary care setting. And again, because it's a simple lab test, then much of the work would be done in this setting. But once the result is returned, you can imagine that there are really two paths. Majority of individuals would get a cancer signal not detected result, and they would return into routine care. And as you saw in the previous slide, at least currently, the plan would be that they should continue their routine care as well as their guideline recommended cancer screening. For the individuals with a cancer signal detected, they would undergo diagnostic workup that would be informed by the tissue of origin result provided to the physician on the test report. So thinking about that as a potential implementation, we have started a study called PATHFINDER, which is a real-world return of results study that looks at this implementation pathway. And so the study objective, the primary objective, is to determine the extent of diagnostic testing needed to achieve diagnostic resolution. And we define diagnostic resolution in this study as essentially the physician ends their workup, and they may end their workup for one of two reasons. They identify a cancer, and so that person now needs to be treated for their cancer, or they have completed their workup and have not been able to identify cancer and believe that they have done all the diagnostic testing that is required. And then we are also evaluating certain performance characteristics. And again, because this is a real world population as opposed to case control, we'll now be looking for cancers that are not hitherto diagnosed. Then there are also some patient-reported outcomes that we'll be evaluating. So the study encompasses 6,200 participants, all 50 years old or older, and we have some baseline questionnaires. But the blood is drawn, and it's sent to a CLIA lab that will run the samples and then send the sample results back to the study team at the participating sites. And of course, majority of individuals will get a not detected result, and they should continue their guideline recommended screening, as you saw on the previous slide. The proportion that does get a signal detected result will also have a tissue of origin result. And so the study team and physicians will collaborate at their institution to determine the best diagnostic pathways and ultimately come to a conclusion as to whether there's cancer or no cancer. And then we follow everyone up for 12 months to examine parameters such as what kind of guideline recommended screening did they also do during that year, whether individuals that had a signal not detected result were actually found to have cancer at some point during those 12 months. And we also looked at patient-reported outcomes at various steps along the way. So this study is actually the next part of that process from training of the test to validation to now actual implementation. And we'll look forward to reporting the results of this study in the future. So I'd like to conclude here by saying that having looked at a variety of different technologies and molecular aberrations, including small nucleotide variants, copy number aberrations, and methylation, that methylation itself appears to be a highly robust genomic signature that we can leverage to identify cancer and to localize cancer, that we've transitioned from whole genome bisulfite sequencing to targeted methylation to improve our limited detection, that we can detect cancers across all stages, and in fact, that many of the cancers that we do not detect are more indolent and therefore not prone to overdiagnosis, and that we can identify tissue of origin with over 90% accuracy, which enables a physician to more efficiently target their workup. And we are now undertaking an actual in-use clinical study that we hope to be able to report out in the near future. So of course, this work was done across a collaboration of a large number of individuals at GRAIL, as well as our clinical collaborators across the country, and in fact, in the UK as well, who is participating in our summit study. And most importantly, we'd also like to thank our participants, the over 100,000 participants in all of our clinical programs who have been absolutely critical in providing their time and their participation into our studies to enable all of this work. So with that, I'd like to thank everybody on this virtual call and happy to take questions.
All right, everyone. Yeah, please either raise your hand and we can call on you, or type out your question and we can read that off as well.
Ryan, let's maybe hop through the Q&A ones first, and then we can go to people who raise their hand.
Sure. Okay, so one question was, does normal and cancer tissue have the same likelihood of producing cell-free DNA from any location in the genome? Is there any bias in the cell-free production?
Yeah, so normal tissue actually does shed DNA, as you might suspect. And because we're looking at blood, white blood cells, which are of course the most common blood cells in the circulation that have DNA, the overwhelming majority of tissue type of DNA that we'll see in a blood draw will be from the white blood cells. So in fact, in early studies, one of the phenomena that we were seeing was something called clonal hematopoiesis, which is to say that as people age, they get, as you might suspect, certain mutations. And so these are somatic variants as opposed to germline variants. And one of the concerns early on in this field was that we were seeing a number of these variants, but these were non-pathogenic variants, this clonal hematopoiesis. That is to say that they were not indicative of cancer. And they could actually occur in some of our most famous oncogenes, TP53 as an example. And so some of the early work involved looking at whether and how it was possible to subtract out these clonal hematopoiesis variants in that analysis. So the direct answer to your question is yes, tissues of all type can shed DNA into the blood. And what our job is to do from both a biochemical standpoint as well as a bioinformatics standpoint is to subtract out what you might call the normal DNA to look for the aberrant DNA that represents cancer.
Okay, great. Another question was, have you looked at repeatability of results by cancer stage, i.e. getting the same results using different blood draws?
So retest reliability. So that is a project that is ongoing to look at retest reliability, and we hope to have that data in the near future.
Okay. Do we have a sense of how cell-free DNA methylome tests might be complemented by metabolic or protein markers?
Yes, so that's an interesting question. Our R&D group is exploring that question itself. One thing I have to tell you about protein markers is that protein markers have existed for obviously quite some time with CA125, obviously PSA, as everybody knows, CA15-3, and so forth. Many of the protein markers have historically been hampered by low specificity. So they can be present in a lot of benign conditions. And in our goals to achieve very high specificity, there's just at least an on-paper concern that these protein markers that tend to have lower specificity may adversely impact that ability to achieve high specificity. But that notwithstanding, there may be value to looking at protein markers or even other types of markers that, we often talk about metabolomics as an example. So there may be value to looking at other types of markers to complement the epigenomic signature that we've been focused on, and that's an active area of research.
Okay, great. As the test is rolled out to the population, how often do people need to be tested? Every month, every year, every decade? Can you speak on the frequency?
So the testing interval is a question that can only be addressed through large cohort studies. It's not something that we have been able to undertake yet. There are two elements that drive testing intervals. One is the change in signal, and then the other is the frequency with which a cancer might arise. Because for single cancers, that's a little bit easier to assess, because breast cancers, for example, again, although breast cancer is itself somewhat heterogeneous, there's a narrower kind of range of what we call dwell time. That is to say, the time during which cancer spends within each stage. As we think about multiple cancers, then we're trying to assess this across a large number of cancers that might have different dwell times. So I think the straightforward answer to that is today we do not know, but it will require some further studies to understand better the relationship between the cell-free nucleic acid signal and signal velocity and dwell time to better inform that question.
Okay, great. Yeah, let's take a question from one of our hands that are raised. Ashley, if you can assist with that.
Yep, Dan, I unmuted you, so you're welcome to speak.
Hello?
Yeah, we can hear you, Daniel.
Hello?
Yes, we can hear you.
Yes, I'm asking a question about detection with methylation assay of germline mutations like BRCA and microsatellite instability. Are you picking those up as well?
Yes, so it is possible to do that. We haven't, that's also part of our R&D efforts, is to see whether those can be leveraged in some of our classification efforts, but right now that's not a specific part of our clinical development program.
Thank you. I think that'd be worthwhile.
Yep.
We'll go to one of these other questions. This one is regarding how GRAIL identified its targeted methylation panel. Could you speak more to how your team reduced the imbalance between biomarkers and patients in your discovery cohort before inputting them into the machine learning model? Did you use models like regression analysis or random forest to reduce the high dimensionality of the data in the discovery cohort?
Great question. Obviously, the asymmetry of millions of potential markers and only thousands of inputs into that feature reduction exercise can be quite a challenge. I'm not the bioinformaticist, but I do know that the team utilized various techniques for feature reduction, and so certainly would be available to talk about that offline and maybe connect you to our bioinformatics group to talk about the specifics of how they utilized, for example, hidden Markov models, et cetera, to tackle those kinds of questions.
Okay, excellent. Arut, you had a question. Could you go ahead and?
Hello.
Hi.
Hi. So I have a question, like the methylation intensity increases over the period, like from stage 1 to stage 4, and the number of methylations occurred in per DNA, or like overall the methylation part is increased.
So what it looks like, at least from the data that we've seen, is that the methylation patterns there are actually present even at stage 1. And so when we look at, for example, tissue of origin accuracy, there's a relatively small change in tissue of origin accuracy as a function of stage. So if in fact the tissue of origin signal were weaker as a function of stage, you might expect a decrement of that performance for stage 1, but that's actually not what we see to a large appreciable amount. So what we believe is that the methylation changes, and many of the methylation changes that we're actually looking at are present even in early stage. And the more difficult challenge is you might say, somewhat more analytical, which is we rely on a being able to identify those molecules that are aberrant. And as you know, I think the first question was about, well, do other tissues shed DNA? And so the proportion of the DNA that comes from the tumor or tumor fraction tends to be lower as a function of lower stage. And that's the bigger challenge than actually the types of methylation signatures.
So that makes like the methylation is the precursor of cancer, or like other way I will put, like no healthy person doesn't express methylation or something.
So I think, you know, in a way you're asking a very interesting question, which is if we take, you know, a population of individuals and look at their methylation patterns and only a very small proportion have cancer, what is that variability of methylation just in, we'll call them 100% healthy individuals? And then as individuals have a variety of different conditions that may not be malignant, what is their methylation pattern? And then individuals who might have pre-malignant conditions, you know, carcinoma, pre-invasive, I should say, like advanced adenomas to in situ carcinomas and so forth. How does that evolve? I think that there's still a lot of work to be done on that front. We have in our population, that CCGA study you saw, we actually have a set of, we have a number of people who had a variety of different clinical conditions that were just not cancer. And we are able to distinguish these individuals from the cancer participants. So our focus has largely been on methylation patterns that are specific to cancer. We know that there are methylation patterns that are present in other conditions, and those may be very interesting for other diagnostic purposes.
Thank you so much.
Stefan, why don't you go ahead and ask your question, please?
I actually didn't have a question. I'm sorry.
Oh,
I thank the speaker for this great overview of the methylation field for screening. It was really interesting, especially for someone who's not specifically in the field. It's very helpful. So thank you so much.
Great, Stefan. Let's see. Have you followed up with false negative results in early stage patients to see if the negative result is due to a lack of tumor shedding metabolic activity versus the amount of ctDNA in circulation being below the test limit of detection?
Yes, that's an interesting question. I think the interplay between limit of detection and actual shedding rate is going to be a very hard question to answer in the absence of relatively large prospective studies that have repeat testing in individuals over time. So those are studies that we're contemplating doing, but today we don't have the data to specifically answer that question.
Okay, let's see, we'll go to something, let's see. Something a little less technical just to change it up. How much will the test cost? And is this necessary to combine with general routine?
I can't speak about cost. So, you know, cost and price are kind of out of the scope of this conversation. I think that one of the most important elements in thinking about rolling out a test, especially one that might be used at a population level, is to make sure that the benefits outweigh the harms, and then B, how it fits into the overall sort of healthcare system in terms of the value that the test brings, and in terms of downstream, you might say, as an example, reduced workup for earlier diagnosis, reduced therapeutic costs, and so forth. And so there's a whole field of health economic modeling that can be done to try to answer those questions.
Sure, thank you for that. Let's see. What is the real world advantage of pan-cancer screening versus tissue-specific screening with presumably better performance characteristics? Will tissue-specific assays inevitably perform better for earlier stage cancers since more specific to the mutational methyl pathogenesis?
Yeah, so it's not clear that tissue-specific assays will necessarily perform better than multi-cancer as long as we understand how we define better, sorry. So as I indicated on that one slide sort of earlier in the presentation, if we line up the 4 currently accepted USPSTF guideline recommended screening tests for, colorectal, lung, breast, and cervical, but if we have someone do all 4 tests, there's a cumulative false positive rate. So any given woman now has a higher chance when she undergoes all 4 tests to have a certain false positive, all of which will be worked up presumably. And so as we think about cancers that are not screened for, if we add on pancreatic, gastric, esophageal, ovarian, et cetera, those are not recommended for screening because they have a low individual prevalence. And so there's no test yet today that satisfies this harm benefit ratio that we're looking for. So as an example, CA-125 is a conventional tumor marker that's available for ovarian cancer recurrence monitoring. It actually is used by some clinicians to try to diagnose ovarian cancer when there's a reason to utilize it. And that's a tissue-specific approach. But the false positive rate when applied on a population level is just too high. So I think multi-cancer testing has the advantage of being a single test, so a single false positive rate across all the cancers it's testing for, as opposed to relying on multiple cancer tests, each with its own false positive rate.
Okay. We've asked a lot of questions, so let's do one more, and then we'll give you a rest since you've been so gracious in answering all these. Do methylation patterns differ from patient to patient within the same cancer type? And how do age, race, and other factors affect those evaluations? Yeah,
so I mentioned to you this concept of clonal hematopoiesis, where small nucleotide variants appear as a function of age. And so we believe that aging probably will have some impact on methylation patterns as well. I indicated to you that there is heterogeneity across cancer types. And so even adenocarcinoma is different from squamous cell carcinoma. And so we talk about both of those, lung cancer, but they have different methylation patterns. So there will be a heterogeneity. Our job, and when I say our, it's kind of the royal we sort of thing, but bioinformatics group is really looking and using their tools to try to identify what's idiosyncratic and so may not be useful at a population level, and what is more uniform and may be useful at a population level. I think that one element too is that in this situation where we accumulate more and more individuals who have a diagnosis of cancer, will continue to grow our methylation database, as well as other kinds of genomic information that will help inform future iterations of this test. And I think one of the elements that will become apparent is that versions of tests in this field will accelerate over time, as opposed to a CA-125 assay, which has basically been the same for 30 plus years. You'll see version 1, version 2, version 3 types as more and more data become available to train and test on.
Actually, I lied. One last question, just because it's from Utkan. Can you comment on how you see exosomes and exosomal DNA in all this? And does it, that's the gist.
Yeah. I think exosomal DNA is obviously a very interesting phenomenon. I know that there's at least one or more companies that are focused on that as a technology. Again, there's a long road from sort of the what we'll call biomarker discovery to validation to implementation, and it requires a large number of clinical samples and the right amount of clinical information to be able to make the right associations. So I think on paper there could be value to exosomal DNA, but I haven't yet seen the data personally to say that's what we should focus on immediately.
Okay, great.
Thank you.
Well, thanks so much for a really excellent talk. And it was great to hear about all the exciting initiatives and all the amazing progress you've made at GRAIL.
All right. Well, I appreciate the opportunity.
All right. Thank you, everyone. And I hope everyone has a great day.
Thank you.